starting the timer. Okay, good. Okay, and here is the question, and here is the question. Right. If you have read and understood, kindly tell me what do you see. What do you see?
This is the mandible, the zygomatic lateral view of the skull.
Okay. Showing what? Is it just the
So in the
zygomatic or?
temporomandibular
Yes.
and the temporomandibular joint is the mandible.
Yes.
There is the medlem and zygomatic one.
Okay, this circle shows something. And can you identify all the structures, 1, 2, and 6?
Okay.
Please.
1, this is the condyle process. 2, this is chronoid process. 3, this is the ramus of the mandible.
Yes.
4 is the angulum of the mandible, and 5 is the body of the mandible. 6 is the mental foramen.
Voice. Yes. And 6 is what?
Mental foramen.
Yes. Can you please tell me what passes through mental foramen?
The inferior alveolar vessels.
And which nerve?
The mental foramen, the mental nerve.
Yes. Branch of? Mental nerve is
the mandibular division.
Yes.
Branch of the inferior alveolar nerve. It's the branch of the mandibular division of the trigeminal nerve.
Good. Okay. Can you please describe the anatomy of the circle joint here?
This is biarthroidal hinge joint.
Okay. Can you tell me which side is it, first of all, right or left?
This is the left side.
Good. And tell me more. Synovial joint and?
Biarthroidal hinge joint.
Yes. Yes. And? It's saddle in shape. Are there any cartilage or meniscus or anything present?
Yes, there is myelin cartilage and
yes.
synovial.
Does it contain synovial fluid?
Yes.
Okay, good.
Synovial fluid.
Yes. Okay. Right. Can you please tell me about what are the muscles which form tongue?
There is intrinsic and extrinsic muscles.
Yes.
The extrinsic is the hyoglossus and genoglossus.
Yes.
And the digastric and palatoglossus and styloglossus.
Yes. You've told me both intrinsic and extrinsic. Okay. What is the innervation of the tongue?
It is the innervation by the hypoglossal nerve, except the palatoglossus, which is innervated by the vagal nerve.
Yes. Your voice disappears. I can't hear everything. Okay. Can you tell me what is the somatic sensation of the anterior 1/3 of the tongue? It is supplied by what? Which nerve?
It is supplied by the lingual nerve.
Yes.
This is
which is a branch of?
Supplied by the chordae tympani.
Okay, branch of mandibular nerve.
Yes.
And what about the taste sensation?
Taste by the chordae tympani, which is the branch of the taste nerve.
Yes.
The posterior stretch is supplied by the glossopharynx.
Very good. Can you tell me what taste modalities are detected by the lung?
The bitter, sweet,
Yes.
bitter and sweet.
Posterior third or posterior aspect of the tongue senses for what? Bitter taste. Okay. And the lateral?
Bitter, yes.
Yes. And the lateral aspect of the tongue?
Sweet.
Sour.
Sour.
Anterolateral aspect of the tongue, it's for the salty taste. And anterior aspect of the tongue, it is for the sweet taste. Okay, please, we'll move on.
Okay.
Yes. What do you see?
This is most likely the CT of the skull.
Yes.
Showing the dural bone.
Yes.
And the symptomatic, the temporomandibular joint.
Can you please identify all the structures from A, B, C, D, and X,
this is
Y,
the
Z?
condylar process of the
Okay.
mandible. And
condyle of the mandible.
Process.
B is?
Yes. Coronoid process of the mandible.
Yes. Yes.
C, this is the ramus of the mandible. And D is the angle of the mandible.
Yes.
Y is the zygomatic bone.
Yes.
And this is the process.
Yes.
X is the temporal bone.
Temporal bone, X is temporal bone, and Z or Z is mastoid process of the temporal bone.
Mastoid process.
Yes. Okay. Can you please, you've already told me what passes through the foramen, mandibular foramen. You've already told me what passes through the mandibular foramen. Which nerve passes through the, yes?
The mandibular division of the trigeminal.
Okay, what is the result of anesthetic block if it's given into the inferior alveolar nerve?
There will be anesthesis to the lower half of the mandible.
Okay. When is it normally given? In which conditions?
During dental procedure.
Very good. Very good. Excellent. Yes. By the dentist. Okay. Which part of the mandible is most frequently fractured? Can you please tell me?
The body and the angle and the ramus and the symphysis.
Body, angle, condyle, and symphysis. Yes. Okay. Can you please tell me which bones does the part A articulates with? This part A articulates with which bone?
With the infratemporal fossa. This is the temporal bone of the temporal bone.
Glenoid fossa of the temporal bone.
Glenoid.
Okay. Glenoid fossa. Okay. Can you please tell me what type of joint? You've already told me. Okay, temporomandibular joint. And what type of cartilage lines articulating surface of temporomandibular joint? Okay. Hyaline cartilage lines.
Hyaline cartilage.
Yes, hyaline. Yes. Okay. And what type of cartilage is the intra-articular disc?
Fibrocartilaginous.
Yes, this one is fibrocartilaginous tissue. Okay, good. Can you name the muscles of mastigation, please?
The muscle of the mastigation is the temporalis muscle and the masticator, and there is the medial and lateral trigger.
Okay. Can you please tell me what are the ligaments which are associated with temporomandibular joint?
There is the stylomandibular, and
there are three ligaments. Okay, so you have to tell me.
The lateral temporomandibular ligament.
Good.
And
stylomandibular and sphenomandibular ligament. 3.
Sphenomandibular.
Yes. Can you please tell me which nerve innervates the mastigation muscles?
The mandibular division of the trigeminal.
Yes, good. Okay, last question. In an uncomplicated dislocation of temporomandibular joint, in which direction this temporomandibular joint will dislocate?
Most likely anterior.
Yes, very good. Excellent. Very good. Done. Excellent. Really happy.
Thank
And
you.
not most likely. Say it confirmed. Yes, anteriorly. Very good. Okay. All right. Anyone else want to give feedback? It was wonderful. Yes, I'm really happy. Today I'm happy. Okay. Very good. Maybe you can learn the origin and insertion and action of mastigation muscles. Can be asked, don't know. Okay. I haven't asked you,
Okay.
but I'm telling you, you can just read them because they are just four muscles: masseter, medial pterygoid, lateral pterygoid, and temporalis. Their origin, insertion, and their action. And
Okay.
maybe the movements of the muscles of mastigation, you can tell which opens the jaw and which closes the jaw, so you should know. Yes, good. Just these two questions I would want to add you. Excellent, good. Right, if you're ready, I'm starting the timer.
Yes, ma'am.
Okay.
Yes, timer is here, and here is the. Right, if you have read and understood, kindly begin your history taking.
Hello, good morning.
Good morning, doctor.
My name is Dr. Ishfaq. I'm one of the doctors here. May I confirm your name and age, please?
I'm Jane. I'm 53 years old.
Nice to meet you again. Can you please tell me how can I help you today?
Actually, doctor, I have actually lost consciousness, and then again regained my consciousness back, and I've been, and after that I've been having severe headache, and I don't know why. And I feel otherwise I'm all right, but just this headache
Okay.
is just too much.
Okay,
My
I'm
husband
really
is there
sorry.
right now. My
Okay,
husband's
okay.
brought me here.
Right. I'm really sorry to hear that out. So is it very serious? Do you want me to give some analgesics or should we proceed?
I think some analgesic will be fine.
Okay, okay. I'll be ordering my nurse that she'll give you some analgesics, okay?
All right.
Okay, I'll be asking you a few questions. Will that be okay?
Yes, sure, doctor.
Okay, so can you please tell me when did it actually happen? Like when you start having these headaches, you had this before, or this is your first headache?
Actually, no. Something like this I had even had experienced previously once. So this was my second time actually. And I was in the kitchen, and then all of a sudden I just lost completely all my sense. And then later on I came back and I see that I'm in the bed.
Okay.
And since then I've been having
Right.
this severe headache.
Okay, so is it in the all of the head, or it's in particular like site? Can you please point out this site where it is?
All over, not particularly, there is no side.
Okay, so Do you think it started all of a sudden, or it was like started gradually?
It just happened all of a sudden, actually.
Okay. Did you throw up, or did you like throw up when you have this headache?
Yes, after I regained my consciousness, I threw up once. Yes.
Okay, so can you please describe the headache for me? It's like very sharp type of pain. It's just dull. It's cramping. It's burning. Can you please tell me
I
how
feel
does it
like
feel?
someone's. I feel like it's it's throbbing inside my head, like someone's pressing on either sides into my head. It feels like that.
Okay, all right. Do you think there's anything which makes it worse, which makes it good?
The headache is. I find that in the morning I have this more. It is more
Okay,
severe, and I take
okay,
some painkillers. It becomes better then.
okay. So how, if you have to rate it headache like 0 to 10, 10 being worst imaginable headache you have ever experienced, how do you rate it?
7, perhaps.
Oh, okay. So it's very severe. So can you please tell
Yes.
me? Can you please tell me? Have been like have you been felt like you are very sensitive to light recently?
Good.
Sorry, doctor.
Have you felt like you have been very sensitive to light recently?
Yes, after I regained the consciousness and I cannot look directly into the light,
Uh-huh.
yeah.
Okay. Have you been experiencing any neck stiffness?
No, not that I can feel something like
Okay.
that. No.
Right. So after gaining the consciousness, do you think you are having like any weakness or any abnormal sensations in the body, any part of the body or anywhere?
Not particularly, doctor.
Not particularly. Have you been experiencing any fevers recently or being unwell recently?
No,
Nothing like that.
no.
Okay. So how has been your appetite recently?
Not so good, doctor. I've been losing appetite.
Okay. So do you think you have lost some weight?
You see, I don't eat much. I don't have
Okay.
any appetite. So I think because of that, I might have lost a few kilos.
Okay. So can you please tell me, do you have any other condition you see your GP for?
I do have, I have hypertension, but I don't know, other than that, I don't have anything else.
Okay. Right. So have you had any surgeries in the past?
No, doctor.
Okay. So is there anyone else in your family who has experienced the same before?
No, doctor.
Okay. Do you mind if I ask you some few more personal questions?
Yes, no problem. Go ahead, doctor.
Okay. Can you please tell me what do you do for a living?
Oh, I was a teacher before. Now I'm retired.
Okay. Okay. So who's at home with you?
Just my husband and me.
Okay. Right. So do you drink, smoke?
No, neither.
Any? Okay. Right. Any use of recreational drugs recently or before?
No, no,
Nothing like that.
doctor. No.
Okay. Right. So do you, okay. So before proceeding further, can you please tell me what do you think what might be causing these problems? What may be the cause?
I don't know, doctor. If you could help me
Okay.
out, it'd be great.
Yeah.
I'm
Yeah. I will be more.
concerned, you see.
Okay. Right. Right. So this is your most important concern and biggest concern, right?
Yes, just to get this headache off, and I don't want to again experience the same thing.
Okay. And what are you hoping us to do for you to solve this out? Okay. Am I right?
Yes, I would really love if you could give me a solution for my this headache and then loss of this consciousness every now and then.
Right. Right. Have you taken any medications recently?
No, just some painkillers at home for this headache.
Okay. Have you had any allergies?
No, doctor.
Okay. How has been your bowel habits and your water works? Any issues with that?
Nothing. No issues in that. No.
Okay. Any muscle pain, joint pain, or shortness of breath you have been experiencing?
No.
Okay. Okay. All right. So thank you very much for your time.
Can
I will
you
Thank you,
get
doctor.
back
present
to you.
your case now?
Okay. Today I have asked history from 53-year-old gentle lady who has came with a complaint of headache, and she has started this before she had a episode of loss of consciousness. Upon gaining consciousness, she started having this headache. She started she was having previous episode of severe headache as well. She's otherwise fit and well. She was complaining of photophobia and neck stiffness as well. Her appetite has not been good. She has no significant medical history and past history. So, considering the situation, I make my provisional diagnosis as the subarachnoid hemorrhage, considering this onset and the worst scenario, worst headache ever. So, but I will also rule out. I would also like to rule out other causes as well, like meningitis, encephalitis, any brain tumors, any history of trauma to the head, and
Okay.
yeah,
How
any
do you
psycho.
think patient should be managed?
So, I would like to manage the patient according to the ABCDE protocol, securing whether his airway is maintained or not. Then going for put oxygen, put the patient on the oxygen, and then take the collateral history at the same time, and then breathing, circulation, disability, and exposure, and doing the full examination, neurovascular examination, and cranial examination in this patient.
How
So
would you
after that,
treat this patient?
I would like to run some investigation in this patient, starting from blood investigations and biochemistry and NCCT head in this patient to rule out any head like pathology. And as I'm thinking this is a case of subarachnoid hemorrhage, I will be discussing this case with my consultant neurosurgeon. I will discussing with the neurosurgeon, and there are few possibilities, like we have to keep patient hydrated 3 to 4 liters of fluid in 24 hours. They give between 60 milligram QID, put the patient on antiepileptics, put the patient on regular these painkillers, and discuss the case with the this radiologist, neurosurgeon, and the possibility. There are few possibilities we can go for, like we can go for burhole, we can go for craniectomy, and we can clip the aneurysm, or we can coil the aneurysm. So these are our possibilities.
Which you will discuss in MDT, of course.
Yes, we will discuss with the MDT and neurosurgeon, involving neurosurgeon, radiologist, and other specialist nurse and others.
Okay, good. Right. Overall 2 minutes extra you have taken, but correct me, maybe I missed. Did you ask for the location, the site where the patient is?
Yes, ma'am.
Yes,
Patients,
ma'am. He did.
it's all over the
Okay,
head.
sorry. And then one question: if the timing, if you asked how the headache started, was there any alarming signs before, or warning signs or anything, or just headache started?
Aura.
Oh
Yes,
yeah.
ma'am. He did not ask that.
I said after the headache,
He
not
only
aura.
said
Yes.
timing.
And yeah, and
Yes.
then
Yes.
if patient
Mm-hmm.
had the head to the floor or to the ground, like if patient
Yes.
was
Right.
standing and patient fell, all of a sudden trauma will be more
Yes.
with the velocity, there could even be a
Yes.
skull fracture. That's why maybe she's having a headache. So
Yes.
when you told me differential diagnosis, then even trauma could be one of the
Trauma.
reason for headache as well, because if she said she was in kitchen,
Yes.
so maybe she was working, she was standing, maybe she was sitting, I don't know. Okay.
Mm-hmm.
This was
Yeah.
not discussed. So she fell, and if her head touched the floor, and with what intensity,
Did.
that can also, yes.
Yes, ma'am. Yes, ma'am. There were so many things, ma'am, but I was like,
Yeah, you
time
need
was
to
not.
practice.
Time is
I
always
realized you asked
time,
most of the
like
things.
always,
You
but
discussed the
still,
severity, yes.
yes. There
Blackout,
were so many
maybe,
questions
yes.
I had in my mind, but like, ma'am, as you know, time is the key.
Yes.
I was
But
I'm
practice is also something,
right. Yes, ma'am. That's what that's how we will improve.
Yes,
That's
I hope
looking
we
for.
will. Yes. Did you ask about
Yes,
the
ma'am.
family history? If anyone else in the family has
I,
had the same?
Yes,
yes,
ma'am,
ma'am.
he did.
Yes,
He did,
yes,
Yes,
ma'am.
ma'am. I
okay,
did.
we'll hear again and we'll get to know. All right, this is mostly, yes, what I think you have missed.
Yes, ma'am.
Yes, others, like he asked about the vomiting, he asked about the visual
Mm-hmm.
disturbance, asked about the
Yes,
fever
ma'am,
or
he did
neck
that.
stiffness, so that
Sensory
was
weakness. Yes,
covered.
ma'am.
Yes,
Mm-hmm. Right.
right. Radiation of headache, maybe if pain radiates anywhere to the neck or
Yes, ma'am.
to the shoulder or something. Did you ask that?
I didn't because, ma'am,
Yes,
she said it's
time.
all over the head,
Head.
and I kept it that way. Then
Okay, yeah, but maybe you can ask radiation, if it's just the
yes,
head or it radiates to the neck or to the arm or shoulder or anywhere. So
like I said, ma'am, these questions are all in my
write
mind,
them
but
down, please.
I was
For
knowing
every
because I
station,
was knowing
for,
time is
yes, I will request you to write down all the questions for every station and practice them yourself in front of the mirror and with the timer on. In 6 minutes, you have to ask all the questions and ask questions and give answer as well yourself. And in this way, you have to make sure that you take complete history, ask everything within the given time. And if you miss anything, then at the end, you can say, because of the time constraint, I could not ask
right.
this. So at the end,
Okay,
at least the examiner knows that you had these questions piled up,
in my
which could have
right,
helped you with diagnosis. And since
right,
the time was limited, you could have asked. And it's
right,
like
right.
even at the end, is mentioning it in front of examiner is as good as doing it for the
Okay,
patient. Yeah. So good.
right, ma'am.
Thank you so much, both of
Sure,
you.
ma'am. Thank you.
Thank
Started the timer, and here is the question. Right. If you have read and understood, kindly begin your examination.
Yeah, I'll enter the examination hall. I'll wash my hand and I'll introduce myself to the patient by saying my identity. And after that, I will give a brief description of the examination and what I'm going to do for him. And I'll seek permission to him. And after seeking the permission, I'll ask the patient to lie on the couch, and for that at 45-degree semi-reclining couch. And after that, I'll ask the patient to put off his shirt and shorts above the waist level, and I will just expose the chest and abdomen of this patient. And after that, I will start by inspection. On inspection, I'll first start from the hand. I'll ask the patient to put the hand in front together, and I'll check the dorsal and ventral aspect. At first, on the dorsal aspect, I'll check any evidence of clubbing, colonychia, leukodystenia, and also I'll do the Shamrock's Windows test to see the evidence of clubbing. And after that, I'll see the palmar surface if there is any evidence of anemia, jaundice, and also I'll check the capillary refill time at the nail bed. And after doing that, I'll check the pulse of this patient at first in the right hand, then on the left hand. Then if there is any radial delay over there, then I'll ask the patient if he has any shoulder pain on the right side or not. Then I'll check the water hammer pulse on the right side. Then I'll also check simultaneously on the left side. After doing that, I'll check the brachial pulse and I'll check the blood pressure at the end of my examination. And after that, I'll look towards the face and I'll check at the lower eyelid if there is any evidence of anemia or not. And also I'll check jaundice by asking the patient to look downwards and lifting up the upper eyelid. And after that, I'll check the oral cavity, if the oral hygiene, and also if there is any cyanosis or not, if there is any dehydration or not. And after that, I'll ask the patient to look on the left. I'll check if there is any evidence of raised JVP or not. I'll ask the patient if he have any tummy pain or not. I'll do the hepatojugular reflex and I will check if there is any raised JVP or not. After that, I will closely look at the chest and precordial area actually. At first I'll look for if there is any visible apex beat or not, and also I'll simultaneously I'll check the respiratory movement of the patient also. And then I'll go for the palpation, and also I'll check on inspection, I'll check the skin condition, if there is any scar mark over there or not, and if there is any evidence of infraclavicular scar mark or any evidence of thoracotomy scar. And also I'll check the axilla if there is any evidence of scar or not there. I'll also check the hair distribution pattern and if there is any evidence of engorged vein on the chest wall or abdomen or not. And after that, I'll go for the palpation, and on palpation, I'll at first try to locate the apex beat, and after locating it in the hopefully in the left fifth intercostal space, I'll just count it from the second intercostal space from the midline. Actually, I count it. After counting it, I'll check for left parasternal hip present or not with my ulnar border of the hand placing over the left sternal edge, and then I'll check with the tip of my finger and if there is any palpable P2 over there or not. Then I'll check for quickly the thrill on the mitral area, tricuspid area, on the left pulmonary area and the aortic area, if there is any palpable thrill over there or not. And after that, I'll go for auscultation. And at first, I'll check the normal breath sound with the in the 4 different area with the diaphragm of the stethoscope. And at the same time, I'll place my hand on the carotid pulse to realize if there is any added sound or not. And after checking the 4 different area, I'll again listen it with the bell of my stethoscope if there is any added sound over there or not. And I will simultaneously keep my hand on the carotid area. And after that, I'll check there is, if I found any murmur over any area, then I will do the accentuation maneuver and also propagation maneuver. Like in case of, if I found any murmur in the mitral area, then I will ask the patient, I will use the bell of my stethoscope. I'll put my hand over the carotid area and I'll ask the patient to lean on the left side, and I'll ask the patient to take a deep breath, then breath out and hold it there. At the same time, I'll just check the radiation towards the axilla. Then I'll ask the patient to breathe normally. And after that, I'll check also if there is any murmur in the aortic area or not. In aortic area, I will ask the patient at first I place my stethoscope diaphragm over the aortic area, and I'll ask the patient to lean forward. And after that, I'll ask the patient to take a deep breath, breathe out, and hold it there. And I'll check if there is any radiation to the aortic area or not. And after doing this, I will also check if there is any evidence of lung crepitation on the, I'll ask the patient to sit on the couch, and I'll check if there is any bilateral basal crepitation over the base of the lung at the posterior side or not. And I'll also check if there is any sacral edema or not. And then I'll again ask the patient to lie on the couch, and I'll check if there is any ankle edema just above the medial 2.5 centimeter above the medial malleolus or not. And I'll also press the calf muscle if there is any evidence of calf muscle pain or not. And then I'll just thank the patient. I'll offer help the patient to dress, and then I'll present the case to my examiner, ma'am.
Very good. Okay, can you present the case now?
Yeah.
Yes.
Yeah. Today I have examined an elderly lady who has complained, who has come with the complaints of chest pain. To complete my examination, I would like to also do the respiratory system examination. Also, I'd like to check the peripheral vascular status of the body. So on examination, on inspection, there is no peripheral stigmata of the heart or respiratory disease, and there was the pulse was bilaterally normal, and there was no water hammer pulse. And by then checking, there was no red JVP, and though no anemia, no jaundice, and no cyanosis, no evidence of claving. On inspection of the precordial system, there was no visible apex beat, and on palpation, there was the apex beats were palpated in the left fifth intercostal space, about 9 centimeters from the midline, and there was no parasternal hip, no palpable P2, and no palpable thrill. And on auscultation, there was no added sound. The first and second heart sound was felt in was heard in 4 different quadrant area. So quadrant Korea, there is no evidence of sacral edema or cup muscle sacral edema, ankle edema, or cup muscle tenderness. So according to the examination of this lady, my provisional diagnosis would be it's normal cardiovascular system, ma'am.
Okay. Can you help me to read this ECG?
Yeah, the ECG, there is positive depolarization in the lead 1, and positive depolarization in lead AVL, and negative depolarization in lead 2 and AVF.
Which
It's
signifies?
actually left axis deviation, most probably left ventricular hypertrophy.
Okay. Do you think this patient would be fit for surgery?
No, ma'am. Actually, left ventricular hypertrophy may be associated with aortic stenosis. So I think at first that should be ruled out, and so after with the opinion from the multidisciplinary team, like in cardiologist, anesthetist.
What further investigations would you ask for, please?
For this patient, I would like to do at first an ECG and echocardiography preoperatively, and I would take opinion from the cardiologist for the operation.
Okay.
Yeah.
If patient is taking any anticoagulants, how would you manage them?
Actually, at first, I would like to take consultation from the hematologist or any local policy or not. Then I would like, according to their advice, I would like to divide them in 2 categories, like if the patient is high risk or low risk, ma'am. If the patient is low risk, we can stop the anticoagulant if it is warfarin, like 4 to 5 days ago, before the operation. And after the operation, when there will be no risk of bleeding and patient will be able to take oral feed, we can start that warfarin pill for the patient. But if the patient is high risk, like recently having within 6 months or within 1 year having any cardiac insult and or any type of valve replacement, something like that. So if the patient may be high risk for blood clot. So for that patient, I would like to stop that actually 5 days prior to surgery, the warfarin, and I'd like to switch over the low molecular weight heparin in therapeutic dose for this patient. And I'd like to stop that before 12 hours before surgery. And after the surgery, actually, when there will be no evidence of bleeding, and actually most probably 6 hours after surgery, we can again start the low molecular weight heparin. And whenever the patient will be able to take the oral food, we can start the warfarin pills. So then we'll check the INR level of this patient. When it will be in range like 2 to 3, then we can stop the low molecular weight heparin for this patient.
Very good, excellent. Thank you so much. Perfect. It was within given time and you answered, okay, I allowed you to talk because at the end maybe you'll get 1 minute extra as Corona time is going on. So you will get this much time to discuss the questions. Good. Thank you so much.
Thank you, ma'am.
And here is your question. Right, if you have read and understood, kindly begin your examination.
Okay. After entering the room, I'll wash my hands and introduce myself to the patient.
Good.
confirm the name and date of birth of the patient.
Very
Then
good.
I'll take the permission from the patient to examine the swelling present in the groin. That would
Yes.
include the looking, feeling, and listening to the lump. Then I'll ask for a saffron to be present throughout the examination. I'll request and help the patient for exposure from umbilicus up to the feet, and keeping in mind the privacy of the patient. I'll ask
Yes.
the patient about any pain at the moment and offer any painkillers if he needed.
Very good.
Then I'll ask to stand him if he's sitting or lying down. After that, I'll start the examination by taking a close look at the groin on both sides, noticing for any noticing of the site, size, shape, and surface of the swelling and the condition of the overlying skin, and look for any scar also. And then
Good.
I'll ask the patient to cough and then see the visible pulse on coughing. Then I'll ask the patient to lift up his scrotum to see the external genitalia and also see the posterior side of the scrotum. Then I'll inform the patient that I'm going to feel the lump, and then I'll ask about any pain at that moment, and then also I'll ask for any painkillers if needed. Then I'll feel the lump for tenderness, for temperature with the back of my hand, and then see the margins of the swelling, its consistency, its surface, if it is pulsatile or not, or it is compressible, and if it is mobile or fixed to the underlying skin, and if it is underlying structure, and if it is fluctuating or not. Then I'll feel the location of the swelling by locating the pubic tubercle as well as the interspheric spine with the inguinal ligament, its relation with the pubic tubercle. And then I'll ask him to cough, and then I'll feel the impulse on coughing. After that, I'll ask if he can reduce the lump by himself, and if there is any pain during the reducing. If the patient cannot reduce himself, then I'll help to reduce him without causing any pain to the patient. After that, I'll do the deep inguinal ring occlusion test and see if the lump is still coming on the coughing or not. After that, I'll feel the inguinal lymph nodes. I'll feel the scrotal neck if it is full or empty, and see if the mass is separable or separate from the testis or not. I'll also measure the swelling by measuring tape, do the trans-illumination test by using light source after asking the examiner to switch off the light with the help of cone, and then I'll inform the patient that I'm going to listen the lump. I'll listen over the lump to see any presence of any gargling sound. After that, I'll thank the patient, help him to put on the gown, and ask if he needs any other help, and then I'll wash my hand, and then I'll go to the examiner to
Have you auscultated
complete
the lump?
Yes, ma'am.
And you'll perform the same thing on the opposite side as well.
Yeah.
All the
I
procedure.
already said I am doing it on both sides.
Yes. And then what would you do to complete your examination?
To complete my examination, I would like to do the complete abdominal examination as well as chest examination also.
Okay, and even direct DIR test. Okay, can you please summarize
deep inguinal ring test.
Yes. Can you please summarize your case now?
Today I have examined a 67-year-old male who presented with right-sided. The swelling is non-tender, and it is pulse. There is visible pulse on coughing, and there is a palpable impulse on coughing also. It is reducible. This deep inguinal ring test is and the swelling is non-compressible.
Okay. Then, how big was the lump? Who got disconnected?
and
Yes, please.
and on a scrotal examination, a scrotal neck was empty.
Okay.
On
okay.
on listening, I cannot hear any gurgling sound.
Okay.
So my
What was
provisional
your
diagnosis is
differential diagnosis? Yes.
okay. My provisional diagnosis is right in indirect inguinal hernia. My differential diagnosis is there may be hernia, which can be direct, indirect, or femoral hernia. There can be superficial like sebaceous cyst, any lipoma or groin abscess. There can be mal-descended testis, or it even can be transplanted kidney. It can be epididymitis or orchitis, or there can be saphena varix or femoral artery aneurysm, or even lymph node. There may be lymph node.
Good. Can you please tell me how should this patient be managed?
To further manage this patient, first I will take the adequate history from the patient. After
Yes.
that, I'll send all the blood investigation, including full blood count, urea electrolytes, and coagulation profile, and also advice for ultrasound examination. Then after discussing with consultant, I'll discuss with the patient about the options of the surgery, including the open and laparoscopic hernia repair. And as the patient is old, so usually I'll go for the open hernia repair.
Okay. Can you tell me what are the types of hernia repair that can be offered to a patient?
There are two types of hernia repair. It can be either open repair or laparoscopic repair.
Yes.
In open repair, there are many operations like herniotomy, and there are open suture repair, which are different types like soldis, Bassani, etc. Then there are complex mesh repair, and one is lichen stain mesh repair. And there are also Astopa repair.
Okay.
In laparoscopic repair, there are two types of repair. There is what we call tape repair and tap. Tape is totally extra peritoneal repair.
Yes.
And another is trans-abdominal peritoneal repair.
Good. Considering that it was an old patient, would you offer the patient mesh repair with the mesh or not?
As in old patient, yes, the muscles and it will be weak, so I'll obviously offer the mesh.
Okay. What are the consequences of offering mesh to the patient?
Consequence of mesh, there can be later on, there can be infection locally, or sorry,
Yes.
ma'am, I'll pass this question. I did not read that.
Yeah. You've answered yourself. Patient is old, so maybe not, because mesh acts as a foreign body and it's a
Yes.
source for infection. So considering a patient
Yes,
is
it
old,
is so.
maybe does not have to lift the goods and things, so maybe does not need mesh repair.
Okay.
Mostly it's the young people who are the ideal candidates.
So
I think
I'll read about it detail.
Yeah.
Yes.
If any of them are general surgeon, maybe they can add more.
Yeah, if Dr. Isfaq or anybody else.
I think
Actually,
Dr. Isfaq is neurosurgeon or something. I don't know.
Yeah, he's in neurosurgery. Yes,
So,
but
yeah.
he did, I think. Okay, no problem. Anybody
Hello,
else
ma'am.
can.
Actually, nowadays, ma'am,
Yeah,
for
Dr. Isfaq.
any surgery, like there is primary repair and the secondary repair. So primary repair is actually the approximating the conjoint tendon and the inguinal ligament, and the secondary repair is always ensured to prevent the future hernia with the mesh, ma'am, actually with proper aseptic precaution. So it is the first choice for any hernia other than the congenital hernia. So if it is not possible, then without mesh it can be tried, but most of the time now the lichen stain and mesh lichen stain repair is preferred, ma'am, as I know actually.
Is it according to the
I
NICE
also heard
guidelines?
about.
Not according
I
to the
don't know.
NICE
I have
guideline.
to
In,
No,
see.
in
I
practical
was
life, ma'am,
asking you about according to the NICE guidelines. So you have
No,
to,
yeah, we
it's a
have to.
homework.
You have to.
You have to
Yes,
find
okay.
it out and tell me tomorrow.
I'll see.
Yeah, thank you so much. Started the timer and here is the question. Once you have read this, tell me, I'll do the next slide. Yeah, please, slide.
Yes, ma'am.
Okay. Right, if you have read and understood, kindly please tell me, how are you going to manage this patient?
Management of this patient, most probably the patient is suffering from acute pancreatitis, and management of this patient would follow according to the ABCDE protocol.
Good.
First of all, the patient's management would be in ITU. So I'll have to consult with the ITU team, and management would be patient would be nothing per oral, started with hydration with Hartmann solution, and intravenous broad spectrum antibiotic, preferably with carbapenems and quinolones, and also intravenous anti-ulcerant to prevent stress ulcers, intravenous analgesic according to the WHO ladder and pain management ladder.
Yes.
And patient should have to be inserted with a nasogastric intubation and also indwelling catheter to monitor the intake output, and we can also give octreotide to decrease the pancreatic secretion, and the pain management preferably would be pethidine or meperidine, the drug of choice. We'll have to avoid NSAID and also any strong opioids like morphine.
Okay, you said you consider it to be pancreatitis. What other differential diagnosis are you going to keep in your mind?
Okay, so the patient could have acute exacerbation of peptic ulcer disease, could be a case of perforation of gas-containing hollow viscus, could be a case of acute cholecystitis, could be even then could be ascending cholangitis.
Can you tell me how would you confirm your diagnosis?
Confirmation would be after thorough clinical examination and history taking and clinical examination.
Yes.
I would have to do some investigation, some bloodline and some imaging. Of the bloodlines, I'd go for a complete blood count, a liver function test, serum amylase, serum lipase, and CRP, and also urea electrolyte. And for the blood, for this imaging, I would go for ultrasonography of the hepatobiliary and pancreatic systems, and also if the patient is stable and if the renal function is good, I'd go for the CT scan of the abdomen.
Very good. What do you expect to find on CT scan?
On CT scan, I would find that the pancreas would be swollen, inflamed, and edematous, and there would be a peripancreatic fluid collection and dilatation of the bile ducts, and also complications of the acute pancreatitis if arises, like abscess or necrosis or the pseudocyst formation. Yes, ma'am.
Pseudocyst, very good. Can you please tell me what might be the causes of pancreatitis or acute pancreatitis?
One of the most common cause of acute pancreatitis is gallstones. Another is chronic alcoholism. There is also iatrogenic such as post-ERCP, upper GI operations that include pancreatic handling, and some drugs such as corticosteroids and thiazide drugs, and also
Infections, right?
venous insufficiencies like insect bite or snake bite, infections like viral mumps or
Very good.
mumps coccidiovirus infection, even
Can
typhoid.
you please tell me the pathogenesis of acute pancreatitis?
In acute pancreatitis, there is a duct obstruction, so there is retrograde flow of the bile, which causes direct damage, to the pancreatic acini, resulting in the release of the proteolytic enzymes from the pancreatic acini. Also, there is direct action or direct damage to the pancreatic acini by virus, bacteria, and there is, due to destruction of the pancreatic acini, there is release of proteolytic enzymes. And that such as lipase that break down the fat, that cause fat emulsification, breakdown of the fat, omental fat, elastase that break down the blood vessel walls, and also there is then there is hypoxemia and also bleeding, which could ultimately result in acute hemorrhagic pancreatitis.
Okay, very good. There are certain scoring systems which are used to stratify the risks of pancreatitis. Can you name few, please? Name of the scoring systems, yes.
Yes, ma'am. There is the Glasgow's criteria, which
Yes.
Assesses the ITU admission criteria of the of a acute pancreatitic patient.
Yes.
Then there is the Ranson score that
Yes.
assesses the severity. There is the Balthazar's scoring system according to the CT scan findings.
Very
There is
good.
Apache 2 scoring system.
Can you please tell me on admission and after 48 hours Ranson's criteria or the scoring system?
Ranson's criteria on admission, on immediate admission, this if age
How
more than
it
55
differs.
years.
Yes, how it differs from on
Yes,
admission to after 48 hours. Yes, please.
Yes, ma'am. On admission, if the patient is if the patient age is more than 55 years,
Yes.
neutrophilic count is more than 16,000, then glucose level is more than 11,
Yes.
and if there is
LDH level.
elevated enzymes,
Yes.
that is
Yes.
LDH more than 300 or 350, or AST more than 250. 200. And in case of 48 hours after admission, if the blood urea nitrogen is more than 5 millimole per liter, if there is base deficit of more than 4, and if the calcium level is less than 2 millimole per liter, and if there's fluid sequestration of more than 6 liters, and partial pressure of oxygen is less than 60 millimeter of mercury. So according to that severity, if 0 to 2 will be 2%, 3 to 4 will be 10%, 15%, then 4 to 5 will 5 to 6 will be 40%, and 7 to 8 is 100%.
All right, this patient is tachypnic. Can you explain why?
Sorry, ma'am?
This patient is tachypnic. Can you explain why, please?
This is because perhaps the patient has developed ARDS and pleural effusion, and there's decreased lung compliance. It could also be because of the irritation of the pancreas, with the resulting in splinting of the diaphragm, and
okay.
And also,
yes, if you will not manage this patient will go into some complications. Can you name few, please?
There are some local complications and some generalized complications.
Okay.
Local systemic complication. Local complications are patient can develop pancreatic neck abscess, necrosis, pancreatic pseudocyst, and then systemic complications such as, in case of cardiovascular system, patient can develop arrhythmia, and lung complications such as ARDS, decreased lung compliance, then hematological such as DIC, then even death, and renal system, a patient could develop acute renal failure, metabolic derangements such as hypocalcemia, hypomagnesemia, hypoxemia, hyperglycemia.
Very good. Okay, one last question. What are the components of pseudocyst, and how should pseudocyst be managed?
The pseudocyst is a localized area of amylase-rich fluid centrally
Yes.
surrounded with a rim of granulation or fibrous tissue. It is managed according to the, it is usually managed conservatively unless the, but surgery is opted if the size is more than 5 centimeter, if it is thick walled, and if it is more than 6 weeks. In that case, we could go for internal drainage by endo-ultrasonographic guided cystogastrostomy, cystoduodenostomy, or cystojejunectomy.
Very good. Okay. Otherwise, there could be, what could be the complications of pseudocyst? Could rupture?
Complication
Yes.
could rupture. There could be
Infection.
hemorrhage within the
Yeah.
cyst. Could be infection. Yes, ma'am.
Very good.
Yes, yes, ma'am.
Yes,
And then followed
infection.
by biopsy of the cyst wall. Yes, to
Yes.
exclude any malignancy.
Very good.
Yeah.
Excellent. Right. Okay.
Thank you, ma'am.
Very good. Excellent.
Thank
You are ready as well.
Inshallah, ma'am.
The
Thank
exam.
you.
Yes.
Please do pray. Yes, ma'am.
Excellent. What are they writing?
Yes.
Yes.
Okay.
Yes. Good. Right. If you have read and understood, kindly begin your station.
Okay. Good morning, ma'am. Okay. Good morning, ma'am. I am Dr. Fatmata, the surgical doctor on call. May I please confirm your name and your relationship to the patient, please?
Hello, doctor. Thanks for speaking with me. My name is Miriam, and yes, I'm the biological mother.
Good.
Okay. So sorry about your child. We weren't able to inform you. So, but before I inform you about the case, I want to know what you understand or what you know about the case. What do you know? What happened to your child?
So it's a bit of a shock to me, really, because I've just been told by the dad that he had an accident while in school, and he's been basically brought in. He's had some scans, but I'm unable to completely get a full picture. Is my daughter okay, doctor?
Okay, ma'am. So your son had an accident. He fell from a swing in school and then was brought in. But then he's right now in the theater because he has injury to his spleen. Spleen is it's an organ on the left side of the tummy, which has different functions. So that's what he has rupture of. So right now he's in the operation room with the surgeon.
That sounds really terrible, doctor. So are you saying?
So sorry about that.
Right.
Am I
Okay.
saying?
Are you saying she is going to have an operation?
Yes. So because it was an emergency, so we could not wait for you, but we took consent from the biological father to do the operation because it was an emergency and he was bleeding.
Right. Okay. But ideally, I wouldn't want my child to have an operation.
But Yes, this was an emergency. It was needed, and then that was why we had to do the operation. And then the consent was given by his biological father.
I completely understand that, but I think it's common courtesy to also inform myself because ideally I wouldn't want my child to have an operation. If you've not yet gone ahead with it, I would want the procedure to stop right now.
Good.
I understand your concern, ma'am, but we cannot stop the procedure as this is the child, and then we have to do the operation for the child. So we have to do what's best for the child, not what's best for you. So we understand all your concerns, but this is what is needed to be done for this child to save his life.
So what do you mean you can stop the operation? I have the right over my child and what I would want for my child.
Yes.
And I'm telling you, as the doctor looking after her, that I do not want an operation. And you are telling me that you would have to go ahead with the operation.
Yes, ma'am. I'm so sorry. Like I said, the biological father has already given consent, and then this the child who's under age, and then child protection too is also responsible for the child, and then we know that this is the best for the child. So we are very sorry, but we have to look for the interest of the child first before any other thing.
Right. Okay. But it's really not the best thing to do. Even if you've asked the dad, we both have parental right over the child. I would want to assume the normal thing to do would be to inform me as well.
We are so sorry about that, but it was an emergency, so we had to do the operation as soon as possible to save his life, because not doing the operation means his life would be in danger and he will die from it.
Right. Okay. I see.
Okay, so do you understand? Do you want to know the complications involved in it, or you're okay with it?
Well, I would want to know everything about the operation. You mentioned about, is it spleen? I honestly wouldn't know what that is. And
Yes, so
what?
like I said, spleen is it's an organ which is in the left upper part of the tummy. So it has different functions. What it does is it helps to how do you call it? It helps in the fighting against infection for the body.
Yes.
It does have that function. Yes. So it being injured, meaning the child could have many complications later on in the future, even after the surgery. Therefore, we will need to vaccinate the child right now after the surgery, sorry, and then also will be on lifetime prophylactic antibiotics for some bacterial infection.
Good. And
Oh dear, this doesn't sound good, is it? So how long will
It's
the procedure
a it shouldn't be more than 2 hours probably, but it's surgeon dependent. But he's in the hands of the best surgeons, so hopefully he will come out soon after the surgery is done.
Right. Okay. Okay. So what happens if, for example, you wouldn't do the procedure?
If we don't do the procedure, the child most likely will bleed a lot, because the spleen is very vascular, meaning the blood supply to it, it's very let's say high. So if we don't do the surgery, rich.
yes.
So if we don't do the surgery, he will bleed a lot, and then that will cost him his life.
Good. Is the consultant expert?
Yes. So, but the one that is my consultant that is doing the surgery is an expert, and then he has handled many of these cases. So I'm sure he will do the best for him as well.
Right. Okay. Okay, that's fine, doctor.
How long patient will be staying in the hospital?
So
When
the
can I
patient will
see
be
him?
staying
Yes.
as long as it's necessary for him to recover, because that is the most important for us. So you can see him as soon as he's in the recovery room.
Good.
From
Tell
the
me more
OT.
about the social worker. What do I have to do for it?
Yes, so this the social worker will be involved for this child's case to hello?
Yes, we're listening.
Yes, the social worker should be involved in the case of this child.
Yes.
So that we know how for the child to be followed up, to
Yes.
know, yes, I think it's about the parental care for the child.
Yes. At the end, maybe you can ask the patient's mother to sum it up for you. So you can
Yes.
say,
So
okay. So both of you are at the same page.
Yes. So with all that I've explained, can you please sum it up for me so I know what you understand and then what you don't understand, if need be to elaborate more on it.
Good.
Right. Okay. So you mentioned my child had a fall from the swing while in school and has hurt his tummy, and one of the organs in his tummy is bleeding and needs an emergency operation, without which he might die. And the operation will be done by one of the specialists who has done this a lot of time. And there are few complications that could come from this, and my child will require lifelong vaccinations, like you mentioned.
Yes.
Okay. So that's fine, ma'am. So if you have any extra questions, you can ask me. If not, I'll leave my number at the nurse's desk, and then you can contact me anytime. Yeah.
Good.
All right. Thank you, doctor.
Thank you. Thank you both of you. Yes, it was good. Except for my concern was that you need a booster.
Child protection.
No. Energy level was too low on your part. Being an examiner, exam candidate, energy booster you need. Otherwise, it was good. Maybe it's too late at your end. I don't know, but it was good, both of you. Thank you, Dr. Dio. It was first time he was simulating for you. So, yeah, and I told him that you are shy, so he has to consider.
Thank you.